Ladies and gentlemen, Dr. Nabil Deeb is one of the world's most renowned cardiovascular researchers and doctors. Currently, he is Director of Cardiovascular Research at Mercy Gilbert and Chandler Regional Medical Centers, members of Dignity Health. He's also an Associate Professor of Medicine and Director of Clinical Cardiovascular Cell Therapy at the University of California, San Diego, Director of Heart Sciences Center, President and Founder of the International Society for Cardiovascular Translational Research, ISCTR. For more than 10 years, Dr. Deeb has been conducting research and developing the newest investigational treatments for advanced cardiovascular disease. He is internationally known and respected for his research and work regarding the use of adult stem cells to restore the health of patients with severe heart disease. His topic today, current status and future direction of stem cell therapy for cardiovascular disease. Please help us welcome to our stage Dr. Nabil Deeb. Thank you for being here.
There's advancing slide here, probably. Let me see. Well, thank you for this long introduction. I left with half of the time, but here what I'm trying to do today is just summarize a little bit the experience over the last 12 years of stem cell therapy, kind of worldwide briefly, and where we are today and where we're going to be in the future. Clearly, the cardiovascular disease and epidemic problem and the prognosis is still not very good. 500,000 patients die of heart disease per year, of heart failure. And we have about 1 million myocardial infarction per year. So clearly, I think the field of myocardial regeneration, whether angiogenesis or myogenesis, is a goal will play important role in the future management and the treatment for cardiovascular disease. Now, the variety of cell has proposed to treat cardiovascular disease patient from myocardial infarction to heart failure to refractory angina. And I know that you heard of embryonic stem cell for potentially the treatment of cardiovascular disease, but so far there is a single clinical trial using embryonic stem cell to treat cardiovascular disease patients. And the only way to treat cardiovascular disease with embryonic stem cell, you have to differentiate those cells to cardiomyocyte, cardiac-like cell, and then transplant it to the myocardium. And that's not an easy task to do. Even in the best hand, you cannot obtain more than 60% purity of those cells. And if you still have embryonic stem cell in the mix, you can build all kind of tissue in the heart. And that's why embryonic derived stem cell is not used in the cardiovascular disease patient. Now, mesenchymal stem cell, cardiac stem cell has been proposed to be one of the potential cell to treat cardiovascular disease. And as you see here, this slide from Dr. Taylor, that you can isolate the cardiac stem cell from the heart, you can expand them, you can put them in Petri dish, and you can transplant them to patient. As you know, there's one phase 1 clinical trial has been presented with cardiac-derived stem cell to treat patient. I think there will be some limitation in terms of harvesting the cell and in terms of the number of cell and in terms of expansion of the stem cell in this approach. But this this route is possible. And as you see here, the scar tissue have improved after the stem cell transplantation. You see the wall is thicker and potential myofiber has been formed. Now, in mesenchymal stem cell world also has been used now over the last 7 years and has been used. Osiris probably the leading company for that, and this is a characteristic of their cell. And those cells obtained from the bone marrow, expanded, and then will be shipped to the lab. And they gave them IV, in this case, for cardiovascular disease in patients with acute myocardial infarction. So there is an advantage of mesenchymal stem cell, allogeneic cell. They can have them on the shelf and we do not see a major immune rejection for them, so you don't need to use immune suppression when you treat patients with those cells. So that's a significant advantage and can be used mainly because the route that they choose is intravenously, so they want to give them during acute myocardial infarction to take advantage of the signal of the inflammatory process during heart attack, hopefully to attract those cells from the venous circulation and retain some of them in the heart to help patients with acute myocardial infarction. And this is just an example that the cell can home in the heart after giving them intravenously in this approach to treat such a patient. And the advantage of this using allogeneic stem cell is that they lack the immunogenicity that was expected before. And in the phase 1, they treated 53 patients and showed that patient with anterior wall myocardial infarction, there might be some benefit for treating patient with acute myocardial infarction with mesenchymal stem cell. Depending on this observation from the phase 1 53 patient clinical trial, we completed 220 patient clinical trial with acute myocardial infarction. We should be seeing the result within the next 6 months, what the impact of allogeneic stem cell on acute myocardial infarction, and the sponsor was Osiris. Now, also another cell with mesenchymal stem cell derived from the bone marrow is a cell was harvested by a company called Mesoplast, and they were bought by a company called Cephalon and Teva. And this is another kind of cell, is mesenchymal stem cell. There's many kind of them. This is another kind that you can, from harvesting, as you see here, 100 ml of the bone marrow, there's approximately 1 to 3 million cell called mesenchymal precursor cell, and those can be divided, expanded, and as you see from one patient, you can obtain a treatment for up to 10,000 patients. And this cell can be shipped, and they can be also be in the cath lab available for injection. They can be frozen, as you see here, with liquid nitrogen, and within 5 to 7 minutes you can thaw them, and they can be ready, as you see here in the last part of the slide, is cell ready with solution for injection. So that make the cell process is easy. And in the animal study, they have shown that one with transplanting mesenchymal stem cell, you can have angiogenesis. Here you see and arteriogenesis, which is small and large blood vessel formed by transplanting those cells. And what you see here on this slide is what scientists believe that they can induce the proliferation of a stem cell, cardiac stem cell derived in the heart. So in this way, if that's correct, then you would expect that the heart to repair itself, basically, from transplanting mesenchymal stem cell. So the phase 2 clinical trial was approved to treat patients with cardiomyopathy, ischemic and non-ischemic cardiomyopathy, with the New York Heart Classification to an ejection fraction less than 40%. 60 patients, and as you see, escalating dose, 25 million, 75 million, and 150 million cell. And there is a control in this patient, and the stem cell were transplanted via the mapping system, three-dimensional system, to target the border zone in this case. So the cell were transplanted to the border zone, and then follow-up was obtained in this trial, was reported multiple times. And the result is that it is safe and can improve the clinical outcome. Depending on that, there's 500 patients will be done. Now, most of mesenchymal stem cell, as you see, they were not delivered intravascularly. And the reason why, because of the clumping of those cells. So they do not give them intracoronary with the catheter use. So this is what's new in my talk about. I talk about the future. So in the future, we have now a catheter that has ability to eliminate the stem cell clumping. You see, this catheter can go over the wire. You can stop the blood flow to allow for stem cell retention if you'd like to, with a balloon inflated. And then you can transplant the cell. And at the tip of the catheter, there's multiple channels to avoid to eliminate the clumping of cells. So it can separate now the stem cell and make the method of delivery is possible, intracoronary. And here what you see, this catheter, so go over the wire, there's 6 lumen in it, and the lumen will separate those cells. And that's what it is. In terms of them, I don't usually talk a lot about the mechanism of stem cell because the mechanism is very difficult to understand, but most of the mechanism usually anti-inflammatory process and repairing the damages through endocrine effects. So you see multiple hormone excreted from the cell to repair, or in some cases like the myoblast engraftment in the tissue. So I think different cell will work with different mechanism. Now, in terms of the immune response for the allogeneic cell, as everyone was worried about, I'm going to show you a histology slide from a human. So a patient who died 7 months after the stem cell transplantation, and what we have ability to obtain his heart and do histological analysis. And what you see here is that is part of his heart where the injection were in the middle in the NOGA mapping, and then we did a histology, and you do not see evidence of immune rejection 7 months later from the human heart. So that's a little bit assuring that there is no chronic rejection in those patients. And here the result of that trial that I just show you in terms of the major adverse event. Clinically. Depending on that, I think they are planning on go to a larger phase clinical trial, about 1,000 patients for heart failure. So that's the mesenchymal stem cell world. Basically, they are going to phase 3 clinical trial, the phase before the commercialization. Now, the mononuclear cell, I think the cell that has been used a lot in Germany and used for acute myocardial infarction, and those are usually delivered right after the myocardial infarction within the first 7 days, and delivered intracoronary with the standard catheters. And that's the Repair MI clinical trial, multiple center clinical trial. Generally speaking, show modest improvement in ejection fraction of 3%. But what we call modest improvement is the best improvement in the world of stenting. In the Cadillac trial, one of the largest stent clinical trial for acute myocardial infarction, the ejection fraction improved only by 3%. So that's what when we talk about modest improvement. And then the patient who has, however, ejection fraction less than 48%, which is more sicker patient, the improvement was about 5 point in absolute improvement in ejection fraction. However, the clinical event is more important and more robust, as you see significant reduction in the clinical events from death to myocardial infarction to hospitalization and the composite endpoint. Depending on that result, the European Union has supported a 3,000 patient clinical trial that will be expected to start in 6 months from now in Europe. And that's where the mononuclear bone marrow stem cells. So in the bone marrow derived mononuclear stem cell, they are also going to the phase 3. In generally speaking, the stem cell therapy now in phase 3 clinical trials before the commercialization. And here what you see the outcome just depicted on this chart with significant statistically reduction in the clinical adverse events. And I told you about the PAMI trial. Now, chronic myocardial ischemia is very, very important field. And we have at least 150,000 patients per year newly diagnosed to have a chronic ischemia. We have much more than that not well revascularized patients. Any patient, when they go to bypass surgery, 30% of patients go to bypass surgery, never had complete revascularization because the surgeon was not able to revascularize one or other area. So that's why it's extremely important, this field. Now, the hematopoietic peripheral blood cell, the CD34, that Baxter is sponsoring, it's become a very important target to treat patients with refractory angina. And the way they do it, they inject the patient with Eupigen, and 5 days later, as you see here, you do euphoresis with this machine. With a few hours, you will be able to obtain mononuclear cell from the blood. So with this technique, you can obtain mononuclear cell from the blood. And then after that, then the mononuclear cell will undergo another process with the Isolect system to isolate the CD34. And After isolating the CD34, then one can collect those cells and then transplant them to patients. In this case, we are targeting specifically refractory angina. As you see now, the cell therapy targeting patient with heart attack, heart failure, and refractory angina. Almost all aspect in cardiovascular disease except the valvular disease. And in the phase 2 clinical trial for Baxter's, they presented this multiple times. And as you see, approximately 164 patients in this clinical trial. Is extremely important clinical trial and showing that there was also improvement in the clinical outcome. And that's extremely important. Not only the refractory angina, but the clinical outcome in general, death and and hospitalization and acute myocardial infarction. And there was significant reduction. This is extremely important in terms of quality of life. Significant reduction in the angina event and improvement in the exercise test. So that's very important, and that's what's going now led to Baxter to sponsor larger clinical trial. That's again phase 3 clinical trial for refractory angina using the CD34, and is going to incorporate about 400 patients in a trial, new trial called Renew trial. Now the mobilization alone of cell did not work, and no further research is going in this area by just mobilizing the stem cell and let them work on their own. The autologous myoblast, no further work in the autologous myoblast. There was a questionable about the arrhythmia and questionable about their efficacy, and stop in the phase 2. But I think we have phenomenal example from the myoblast to show myocardial regeneration. So the cell exists underneath the basement membrane around the myofiber. You can isolate them from taking a biopsy of 1 to 2 grams of skeletal muscle. Every 1 gram has about 5,000 cells. You can expand them in the cell laboratory and then transplant them. You can obtain up to 600 million cells within 4 weeks. And those are autologous. And remember also the Baxter cell CD34 is autologous cell. And then you can transplant them. But here, with the transplanting to patients who are candidate for heart transplant, and then taking the heart of those patients and do histological examination, you see here within the circle, a myofiber and myotube aligned parallel to the healthy tissue of the heart. It's a wonderful example of regeneration of tissue. And that's why I'm showing this slide. And on the nuclear imaging, also you can see survival. You see in a scar in the upper row, and then after in yellow, and then after cell transplantation, you see survival of the cell with a new muscle. And that data was published before. Now, the catheter technology for cell is extremely important. And we use the myoblast for the catheter delivery for proof of concept in phase 1, myoblast and cell delivery. And again, it showed improvement. And you can follow the tissue regeneration with the NOGA mapping. So this system is going to image the heart in a 3-dimension, is going to be used in the CD34, was used before in the myoblast. That's for direct injection into the endocardium. So endocardial injection, you see the scar in red, the area of heart attack, and the dark dot, those are site of injection. So you can distribute your injection perfectly well. Now I'm going to skip those. This is also a slide to show you viability of tissue after cell transplantation. See in red, cell transplant, and on the left side, you see the red area is gone, reflecting in new tissue. That's NOGA mapping done at 3 months after the stem cell transplantation. Now, just briefly, Adipose derived stem cell also was used in the Apollo trial. You might need, just to make you aware of it. And I think in the future, 2 things is coming. the induced human pluripotent stem cell, and I think that's really far from a clinical application. Will require, because it's modified cell, engineered cell, and the minute you start engineering the cell, there's a lot of regulatory requirements attached into it, and it's going to be far from it. But this is a cell taken from fibroblast, and you can make it like cardiac-like cell. And you can make actually cardiosphere from those, and you can transplant the cardiosphere to the myocardium. Those are beating cell, continuously beating cell. So that is a potential in the future. As you see here, cardiosphere, taking it from fibroblast. So fibroblast making a human-induced pluripotent stem cell, taking cardiosphere, and you see the whole cardiosphere. And you can deliver this cardiosphere via catheter, actually. And here, what to change geometry, that's all. And stay about 1 hour. 1 hour later, you start beating. The other area that I think will play important role in cell delivery, and not delivery, cell retention, is the matrix. Now you can take the heart, you can decellularize the heart like what you see here. After you decellularize it, becomes skeleton white color. You can make it isocube, you can make it powder, and you can make it solution ready for transplantation. And it is safe on 18 animal that we did already in the pig. And I think mixing that matrix with the cell might increase the retention of stem cell. And that's become another important area for cell therapy. As you see here, we can induce myocardial infarction, transplant matrix in those patients. That data is reported already last year in the American College of Cardiology, and now is going to be in phase 1 clinical trial in a human. So that's where we are. Here's the matrix, as you see from the heart, how it looks under electron microscopy on the right side, and in its original state. And here on the left, that's the one was injected after its process. The matrix can reconstruct itself in the body temperature within approximately 7 minutes. You can see that electron microscopy reconstruction of the matrix. And thank you for listening. I know a lot of material, but I know also I think, over time.
We actually do have a nice thank you to Dr.
You are not
Deeb.
over time.
You're not over time. we do have a few moments here if anybody has any questions for Dr. Deeb. Or you may prefer to ask those privately.
Very good.
All right. In any case, thank you so much for
Thank
joining
you.
us today. We appreciate that.